This video introduces the IMA surgical training model, developed in collaboration with WetLab Inc. The IMA pedicle is grasped and elevated using arm 4. Peritoneal incision is initiated at the base of the pedicle. As the incision is extended, frequent re-elevation of arm 4 is recommended to maintain optimal exposure. The dissection is guided along the dorsal areolar tissue plane, often referred to as the bubbly layer, which is faithfully reproduced in this model. The model is engineered to facilitate entry dorsal to the hypogastric nerves. By carefully dissecting along the posterior aspect of the mesentery, the right hypogastric nerve can be identified. By applying a push-up maneuver using arm 1 and proceeding laterally, the left hypogastric nerve becomes visible. The peritoneal incision is extended cranially to the root of the IMA. With particular attention to avoid traction injury to the duodenum. Use arm 1 to provide gentle upward counter-traction, using the autonomic nerves as landmarks, to safely mobilize the IMA pedicle. Continue dissection toward the confluence of the IMA, being mindful to preserve both hypogastric nerves. The visceral branch of the right hypogastric nerve should be identifiable at this stage. Maintain tension on the dorsal aspect of the IMA pedicle using arm 1, and proceed with nerve-sparing dissection along the autonomic plane. After identifying the visceral branch of the right hypogastric nerve, perform its selective division. The perivascular tissue surrounding the IMA is dissected in preparation for vascular control. Using the left hand, grasp the anterior adipose tissue of the IMA to continue circumferential dissection. Following transection of the IMA, the left hypogastric nerve, located dorsal to the vessel, is then carefully divided. The assistant should grasp the anterior fat overlying the inferior mesenteric vein, IMV, while arm 4 continues to elevate the IMA pedicle. A peritoneal incision is made caudal to the IMV, and the mesocolic dissection is advanced along the posterior mesenteric plane. Caution is advised to avoid entering the plane dorsal to the ureter, which is more accessible in this model. The dissection should remain true to the mesocolic posterior fascia to avoid misdirection. As dissection progresses, adjust the position of the assistance instrument or arm 4 as needed to maintain a clear operative field. Asking the assistant to elevate the dorsal mesentery may further enhance exposure. Upon identification of the gonadal vessels, proceed with adequate mobilization in preparation for IMV and left colic artery (LCA) control. Utilize the surgeon's left hand for push-up maneuvers and to apply counter-traction toward the retroperitoneum. For IMV and LCA division, determine the precise point of transection. Once the IMV is clearly identified, maintain the dissection planes and perform both sharp and blunt dissection along the ventral and dorsal aspects of the vessel. After vascular division, continued mesenteric mobilization is encouraged to complete the procedure efficiently and safely.